I'd like just to talk a little bit in my presentation about the things I've seen from the national level, which are totally different than the things I've seen from the state level and other areas of experience. The things you always wonder about when you're working your tail off in your practice locations and working your same at boards and executive committees for Michigan pharmacists. There's a whole different level of opportunities and a whole different level of participation when you get to be a national officer, and I'd encourage all of you to take a chance. I know Andy Young is going to, he told me today, hopefully it isn't privilege, he's going to run for Speaker of the House at APHA, and I think he'd be a great one. So I encourage all of you to take that opportunity if you get a chance. One of the things I will quote several times is pharmacists are capable providers in an incapable system. By that I mean we're highly confident, we're highly educated, we like people, and we can take care of patients, but the system doesn't reward it. One of our jobs is to change the system and share the responsibility for doing that. We're the one profession that knows both the therapeutics and the economics of medication use. Nobody else does that. We can own patient safety, and then we have unique expertise, roles, and access to patients that we need to leverage into moving pharmacy practice forward. Those, among many other skills, are what pharmacists bring to the table. As uncertainty across the U.S. and most of pharmacy circles, Michigan's not alone, Minnesota, no matter how many opportunities you have, there's just as many challenges out there that you have to work against. Challenges and barriers include competency questions. Most other health providers have no idea what we do. We do it so many different places in so many different ways. That's something we have to fix. There's lack of care exclusivity for pharmacists. Nurses would love to eat our lunch and are doing it in some practice arenas. We have to find a solution to that. Other healthcare providers don't know our value, and PBMs continue to desire to control patient care services, our care services. We have to work hard not to let that happen. State practice acts vary. Every state is different. If there's anybody here from Alabama? Nobody? Good. They have probably the least progressive practice act in the country. They're one of the few states that don't have collaborative practice. They're over-regulated in so many ways. We're very lucky to be from the Midwest and have opportunities that they only dream of at this point. But in order to be effective as pharmacists providing patient care, every state is going to have to improve their Practice Act, and as I'll talk about later, the federal government and our provider ask, we're not wanting them to set the standards, but what they hopefully will pay for if we are successful in our Practice Act on a federal level will be what your state Practice Act allows you to do. So it's very important that your state Practice Act lets you do the things that potentially we're going to get paid for. I've got no financial conflicts. I work with pharmacists, technicians, and student pharmacists, and hopefully as well as you, I'm constantly trying to reinvent my practice and my pharmacy, or I'll be long since out of business. I think the sign of the times is something that we all have to do, is that no change is not an option. Technologically, not a desk, but I'll do it. The objectives, as Kathy said, I'd like to give you a lot of information from the national level that I'm aware of, and give you some of my opinions, and they're only my opinions, not APHA's, of how they affect our practices and what we can do to improve our daily lives and do what we really like to do, take care of patients. The future of pharmacists, I really believe, is providing care, which leverages one thing, their access to us, because we're everywhere. Pharmacists are in hospitals, long-term care, infusion business, specialty business, community pharmacy business. We're the most accessible provider, healthcare provider out there. And we have to provide quality patient care services, but there's a lot of discussion on what word we should use: payment, reimbursement, and the word that's been most approved of is coverage. We want access and coverage for pharmacist services. There's unprecedented opportunities. My pharmacies do a lot of medication management, MTM, through outcomes, through HMOs, through health systems in our area, and it's growing. The new CMS directive guideline letter that I'm sure many of you have seen, there's going to be a lot more opportunities in Part D Medicare plans to provide MTM. There's growing evidence of pharmacist value It might not be obvious, but there were articles in the Wall Street Journal, coming out of the AMA, coming out of the American Academy of Family Practice, most of them positive, that pharmacists can do more, need to do more with the shortage of potentially primary care healthcare providers. New grads are trained to innovate. We owe them that they have the opportunities to innovate. Michigan has a great school of pharmacy. Minnesota has a great school of pharmacy. And we really have to make sure they can use the skills that they've been educated in, and they will innovate the practice in order to make it better for everybody. ACA opens the door further with the Innovation CMMI system, and CMS are very pharmacist friendly. There are pharmacists from many areas of the country that are doing consulting for them, working for them, and being very positive selling our message. And media, public and policymakers are increasingly aware. It's our job to continue that awareness. JCPP is a huge organization. You can see in the small alphabet soup that all the national organizations, many national organizations are a part of and are members of. There's a 2015 JCPP Vision of Pharmacy Practice that was just eclipsed by a new one in November, which makes the vision even more patient-focused. Essential and accountable are key words in that. We have to be accountable for our actions. Patient-centered and team-based healthcare. You're going to hear those buzzwords over and over again. But I think this vision statement is something we could all take farther and forward and make our practices better. Those national organizations have all adopted the vision statement and will be using that along with their individual missions in national pharmacy. We need to focus. We're distracted. We do things a lot of different ways in a lot of different places. One of them is the patient care process. Even though we practice in different locations and different settings, other professions, whether you're a physician, a dentist, a nurse practitioner, physical therapist, have a set patient care process. One of the things on the national level we're trying to do is make a basic patient care process that you can envision using in any place that you practice pharmacy. Quality measures and standards. Payers aren't going to line up to pay us unless they know that we are doing what we say we're doing and that we have the competency to do that. We need all the tools we need all the tools necessary to provide good care, and that includes health information technology, being able to have all the documentation, all the care plans, all the notes from any other pharmacist, healthcare provider at our fingertips to provide good care and continuous care for those patients. Standards and accreditation. There's places where it already exists. Pharmacy is one of the few places it's not done across the board, and later I'll get to the pluses and minuses of accrediting pharmacies. Evidence of value. We need value that's just not provided by pharmacists and pharmacies and pharmacy organizations. We need independent sources. A large company called Avalier was hired by APHA to look for evidence that's not pharmacy initiated. They have more credibility when we go to the Hill to try to get provider status. And then in the end, we can do all these good things to keep patients healthy, but we need to get paid or covered. Those services have to be covered. One thing we have to think about as healthcare providers is that there's one healthcare team, and we have a role, depending on our practice setting, in all healthcare teams, to a much high level or to a less significant level, all depending on the healthcare team. We have one profession. We're all pharmacists. We do many different things in many different locations, but other professions look at us as pharmacists. So how we do things, we have to remember, it's just not us in our individual arenas. We have to be trying to advance the profession as a whole. When we've gone to the Hill trying to get guidance from key policy and congressional members, and they're all telling us the same thing. If you're not all united and you're not all talking on the same bill about the same thing, don't even bother to come. So we're pharmacists, community, hospital, specialty, long-term care, infusion, really doesn't matter. We all win if we go to the Hill together. And one patient care process, I touched on that a few minutes ago. The new health care system, which we're having a hard time paying for, is also giving us opportunities, and it's been looked at very closely on ways to change it and to make it affordable for more people. It all centers on access, quality, and cost. They want more coverage for more people in more areas. What better place than to have pharmacists involved? They want quality, and people practicing at the highest part of the top of their education. There'll be different payment models, so much different than we have today, but there's nothing that won't be looked at. Pay for performance, integrated care models, cost sharing, bundled payments. There are many, many that are on the table. It's hard to say which one will win, although we have a hybrid and lots of different payment models depending on what's being paid for. And then reducing costs. I don't think there's anybody in the room that doesn't think we have to find a way to control healthcare costs. But I don't think that's a bad thing for pharmacists, because medications are part of that issue, and we are the medication experts. Healthcare trends, they're shifting risk, but you don't get reward if there isn't some risk. You just have to have smart risk. ECOs and patient-centered medical homes are examples of different risk models. You have to know where to take intelligent risks, but there will be risks as far as payment's concerned. If it's pay for performance, you have to deliver on what you say you're going to deliver for the patients. Health plan designs are pushing consumers to make better informed healthcare choices. Pharmacists, in most instances, are very nice people. They take good care of their patients. And we have to leverage how well we take good care of patients into being their choice for different services that we might not be thinking we've ever been able to deliver before. And publishing report cards on the quality of care has been phenomenal for our business. In Minnesota and Michigan, I'm guessing, isn't much different. Every doctor is evaluated on just about every disease state that they practice in, and then it's aggregated on a community level, a clinic level, and then a health system level. And how they met their diabetes outcomes, hypertension, cardiovascular, you name it, mental health. They're valued at those things, and they're rewarded with higher payments or bonuses. And many of those, if not all of them, involve medications. And we've been able to contract with our clinics by saying, what can we do for you? How can we help you? And sometimes it's not what we think we're going to do, but what's important to them has to be important for us. So we've improved diabetic outcomes. We do adherence programs for them. We do many other things that's enabled for them to contract for blocks of time where we put pharmacists in the clinic with the doctors, which is exactly what we wanted to do. There's going to be disruption in the marketplace. Whoever does it well, whoever does it that has the best value, high quality, and at lowest cost will get the jobs. So how can we be on that team? This is a draft of the patient care process I talked about a little earlier. Don't mind the small print, but that's also been before JCPP, all the pharmacy organizations. It's been through most national associations. And you start at the top, you collect your data, you assess, plan, now I'm at the bottom, and implement, evaluate, monitor, or transition, and start over again the next time you see the patient or something else happens in their health. In the fine print, and this will be published for everybody to see by most of the national organizations. But this makes common sense. So whether you're in a hospital practice, community practice, specialty practice, infusion practice, these things are believed by the national associations to apply to all those processes. And that's getting to a common way to see patients, to do things in a single process that other healthcare providers will recognize and reward us for. Primary patient-centered medical home, we'll talk a little bit about that. We are very lucky to be in several of those where we practice. That's my resident, and not one of my residents, and not pharmacist. She does this job not location dependent, and she's sitting in a chair in a clinic, but she does it in the community pharmacy, she does it in the group homes and the long-term care homes we do it, but it's still the same process. Her job is appropriate, effective, safe, and adherent medication use. Part of the physician-patient-pharmacist relationship that's necessary to provide good care. It's a constant information sharing. It allows you, for physicians, to allow you to have access to electronic medical records, and it provides better patient care. There was just an article in the Wall Street Journal this week talking about Pennsylvania and not having success with patient-centered medical homes. In fact, it costs them more money to see patients. And last week there was an article in the Star Tribune, which is Minneapolis' newspaper, showing where they save 10 to 11% providing patient-centered medical homes. So I think there's a future in it. I think other people will learn from other providers and share ideas. But there has to be a pharmacist in patient-centered medical homes. There's just no way for it to be effective without us. And it's something we should all strive to be part of somebody's patient-centered medical home. Our practice needs to focus more on patient care, and I'm speaking both for myself, but for APHA and other national organizations. We have to have a practice model where we're part of the team, and again, it doesn't have to be location specific. As long as you have access to EMRs and EHRs, you can document two-way, bidirectional, interoperable, very possible. Or get your information through your pharmacy software from an HIE or Health Information Exchange. And from those, all the money that the federal government has been dropping into accountable care, buying electronic medical records for physicians' offices and other providers, just about everybody but pharmacists, is this huge amount of data that they'll be able to compare and hopefully show that pharmacist services stand out and are a lot better than other providers who are doing the same thing we want to do. We have to have quality measures and consistently elevate pharmacy practice. And when we have patient care engagement, we'll just be engaging them in a more thorough manner. You can do it, like I said earlier, in multiple locations. Doesn't matter where you practice. You can do it in employers. We have several employers. We go out every 3 months and do screenings. We talk to patients that are identified as high risk. Hospital pharmacists, physicians' offices. You'll see more and more pharmacists eventually working in the LLCs of pharmacists and doing it as a separate company, and seeing patients in their home or calling them if telephonic is the only way you can get a hold of them. The big difference between ACOs and medical homes is the premise they were started on. ACOs is a financing model. At the end of the day, they share risks and there are cost thresholds, and Medicare, the federal government, CMS, set a number, and the money that's left between what they're able to operate and what that number the government sets, they get to keep and share with those folks in there. There's been several tries in the legislature to get pharmacists required to be in ACOs. The most recent one was Senator Harkin, wanted to be stated in the ACO, not mentioned, wasn't successful, but it's been brought up again as the SGR and different payment models for Medicare are brought up there, but it's not required. But most ACOs have started at that pharmacist. And then the patient-centered medical home is a care model. It's a team-based, comprehensive, coordinated care, either by, it says physician here, but most of the ones I know are advanced practice and nurse practitioners, in order to get good care for everybody and identify gaps in care. Although shifting risk gives us more opportunities, there are some downfalls and potentially some problems. But shifting risk is a model that the Accountable Care Organization uses. Global payments, here's this big pot of money, you take care of the patients. The capitated payment in the 60s and 70s was the big rage. It only caught on a few places, and most of the time it wasn't successful, but now it's being raised again. And then shared risk and savings contracting seems to be working well. We have a shared risk saving contract with several clinics, and it has been given us some net from doing that, along with a lot of personal satisfaction. But the big question is in the red. Where does a profession supported largely by product-based reimbursement fit within these models on accountability for outcomes? Where's the value to the patient and the healthcare system? The product doesn't have much value anymore. It's a commodity. The service does. Is there a room for a hybrid where you have both product and service? I think there is. And that product gives you a patient base to provide service to. Again, consistency in a patient care process is what we have to prepare for. Patient-centeredness and patient engagement, those are buzzwords in the federal government and Congress all the time. How to function on a healthcare team. I think that's something we're trying to do in colleges of pharmacy and interprofessional education. We're getting better at it, but I know I had zero when I went to school, and there's not been very much of it before that. But if you don't know how to function on a healthcare team, it's a different kind of team, and you have to do it well in order to be able to contribute your resources. So I think it's something that you'll see more colleges picking up on. Accountability for patient outcomes. Most pharmacists, not all, and there are many in this room that probably don't treat a patient that way, but you see them, you do whatever your job was, you give them their medication, you counsel them, and then until they have a problem, until they come back, you don't do anything with them again. It's not how most of the other healthcare providers work. So we have to have accountability for patient outcomes until they tell us we shouldn't have. Managing risk is nothing we really have been trained in. Quality metrics, how to document the positive things that we do. And we have to look at different care delivery models. I think student pharmacists and new graduates will start helping us figure out those problems and find new ways we haven't even thought about. And then advocacy. We just aren't active enough with our patients, with other healthcare providers, and with congressional and legislative authorities. We all think we are. I think we do a good job, but we have to go get farther. We've got to improve access, quality, and cost. And the only way we can do that is improve efficiencies using pharmacist patient care services, using more support personnel that support the pharmacist. Our technicians do a phenomenal side on the dispensing or order from fulfillment. We're going to have find ways to use our staff doing things to support the pharmacist delivering patient care. You can't make the appointment, sit the patient, do all the documentation, see the patient, and then go for it and be economically viable. One of the successes pharmacists have had in the last couple of years is the Immunization Neighborhood concept. And it's a new word. You can hear more of it. The CDC is picking up on that. But in a year or two, I think we'll probably provide more flu vaccinations, even influenza vaccinations than any other provider. It's been great for us. But how can we leverage that into new patient care services and get the public to know that we do more? Every time we get to do this, there's cost savings to the system, there's no office visits, patients are happy, it's quick, and pharmacists have done an excellent job. Just a little bit about my practice. Minnesota, and if you look at the right-hand side, the UP is not that far from Minnesota, if you go across the tip of Wisconsin there. But we're on the north side of the Twin Cities. It is white right now, so that's a pretty accurate map. We just moved our oldest pharmacy, which has been in business since the 1860s in several locations, into a new clinic. We've had to adjust, we've had to work with their workflows. One of the interesting things was we were really worried about our immunizations. We can't advertise them in the clinic, that's part of our lease. We actually did more immunizations this year than we did last year. People came in asking the front desk of the clinic, where's Goodrich? We want to get our flu shot. So I think that's positive, it's not a barrier. It certainly is nice having access to the healthcare providers. The challenge is getting them used to us. And if you look to the left, the left of the sign, I didn't know I'd have that reflection in the window, but there is a Michigan cat that you can barely see the roof of in the clinic parking lot. I'm sure you've got many places like that here in Detroit and the rest of Michigan. We've built a lot of relationships with physicians. And part of the way we've been doing that is asking them, what can we do for you? And surprisingly, it's not things we've even thought of. First, they want us to okay refills and to send them, e-prescribe them. Well, we didn't have access to EMR, but then because what they wanted us to do, they gave us access to electronic medical records and documentation. And over several years now, we can even remotely document patients when we are too busy at work, we can do that at home. Every doctor is different, every provider is different. You have to tailor what you can do for them. But the key is to ask them how we can improve their practice. Convince them if they use a pharmacist, they can see more patients. We're not taking business away from them. We've been doing that in our pharmacies that are in clinics and also our pharmacies that are not in the clinics. But once you build those relationships, there's a lot of potential for what you can do. Patient-centered medical home. You can be on the team of providers if you contract with the clinic or are on the clinic. Most clinics in our area are a little bit smaller, so they can't afford a full-time pharmacist. So they're asking us to fill that role, both in the pharmacy and in the clinic. Coordinating care. One of the things we need to do is have more warm handoffs with our colleagues, hospital pharmacists, infusion pharmacists, long-term care pharmacists. We may fax them a med list, or we may send them some information, but it's not done routinely. But in order to coordinate good patient care, medication safety, transitions of care, we're going to need to do that, and that's part of a patient-centered medical home, and one of the requirements in Minnesota to have one, so pharmacists are critical there. Enhanced access. If you're a community pharmacy, telephonically you can provide care to the patient. You can have access to the electronic medical record in your remote pharmacy and still be part of the team. Patient engagement, a major source of misunderstanding and medication problems. are the fact that patients don't buy into what the medication is for or don't understand what it is, and we do a very good job, better job than other healthcare providers handling that. Comprehensive care, identifying the gaps, good MTM, good managed care, medication management. Collaborative roles tend to develop after you've made that initial relationship with the physician and other healthcare providers. Whenever you have a conversation with a physician or a healthcare nurse practitioner or a PA, you start out by asking, what can we do for you? Where are your problems? Where are your gaps? But they have to understand what we're capable of. They don't understand how well pharmacists are trained, what you do every day, and how you do it. So we give them a list that we can do. We give them a list of how we can save them money. And don't expect any results on the first conversation, but eventually we've had very good success. They're feeling stressed too. They have to change their practice just like we have to change ours. And it's given us bidirectional access to clinical data, which is extremely important. And if we have aligned financial incentives, there's a myriad of ways that clinics and other healthcare providers can get bonuses and share bundled payments. Pharmacists won't have that option unless they're working with a physician. And also along those lines comes collaborative practice. What we found is, you mean you can't do that? Why can't you do that? You found all these problems with this hypertensive patient, just change the medication. Well, we can, but we need a collaborative practice, and this is what it should say. We started with one to do refills for them, and all these different things we have collaborative practice for. We're also trying to improve that with changes in our Practice Act in Minnesota. And health system alliances, we do adherence programs for several big health systems. We do training and evaluating projects for them. We do research projects for them where we want to see if a particular thing will work and in a particular manner of care. And we do lots of health outcomes testing. As mentioned earlier, how can I help you with your patients? Make suggestions, but they'll let you know what they really want. We have one clinic that just wants us to meet with the pharmacist reps and handle their samples. We're fine doing that because that gets us in the door. And expand patient panel size, meaning if a pharmacist is involved, the provider can see more patients. That's dollars in their eyes. And as long as they can pay you a fair value for what you're doing to help them see patients, it's just a practice model they've never experienced before, especially in a family practice clinic. And also a pharmacy has to be related in Minnesota. They have to have some pharmacist access via patient-centered medical home, which is, in the future, will be all that their medical plans will pay for. Our services, when we expand our roles, have to be specific, and you have to be defined what do they do. That's the patient care model we looked at there, process. They have to be predictable, and can we consistently provide them at a needed level of service. Another reason we have to all provide care in a similar manner, and we have to have competency in order to advance everybody. And how will public payers measure our value and outcomes? That still remains to be seen. We have to test that, but if it's not measurable and we don't provide value, we're not going to get paid for it. The activities, like I said before, state scope of practice changes. I think every state could try to get more patient care items in their practice. Outreach to medicine. Most of the adversity and the problems we've had with medicine, both on a state and federal level, is a misunderstanding of what we're doing and what we're trying to do. So the first step in any process is saying, if you're changing your scope of practice, sit down with your state or county or however your medical organizations are organized, and let them know what you're trying to do. Take their input before you present it to your legislative body. And it's been remarkably successful in most instances. You find out you don't have as much opposition. You can tweak it. California's provider status law is a classic example. Once they educated the California Medical Association, changed some language so the physician would always be notified of changes, they really weren't against pharmacists providing advanced practice patient care. A lot of opportunities start out with star ratings. Shared pay for performance. There are billions of dollars out there for doctors and clinics and health plans and PBMs if they get good adherence, not just possession ratios, but good adherence and good outcomes. We've had several gaps in provider skills where we suggest, do you have any providers that their skills aren't up to snuff? Whether it's diabetes, because like I talked earlier, there's those measures that are out there, quarterly or semi-annual or annually, they're all being put on the dashboard of how they're working. And then we've gone and worked with those providers in a very non-threatening way, and the clinic's been thrilled. Now their new providers always have several sessions with us just to let them know what we can do, how we can help them, their practice, and how we can work on their team. Minnesota Department of Health measures, every year there's new ones and new goals for clinics. Knowing what they are and how to present them is really important. And specific population needs. We have great success with county and state health departments. Immunizations, now we're considered a go-to place for them in our area. MTM Part D, state and private payers, no pool of money is too small for us not to try to figure a way to get paid for our services if we have access to it. Medication adherence, everybody thinks that's the answer to the problem. Certainly insurance companies do. It's just part of the puzzle and one of the many things that we can do to improve health outcomes. I talked a little bit about referral. We really need to do successful handouts with our colleagues. It's one of my community pharmacy residents. On the right is a hospital pharmacist manager and his hospital pharmacist. We have several programs. If they know that the patient is our patient, we're exchanging information on all those patients. And after 30 days on their transitions of care program, we have a warm handoff. We have a question, we can talk to a pharmacist, so that patient has a pharmacist on board all the time. We need to see more referrals between pharmacists and other areas of care in order that the patient always has access to a pharmacist. Credentialing is something you've seen if you practice in a hospital. It's been there a long time. In clinics, there's credentialing, and there's privileging also in hospitals. You're going to see more in pharmacies. The payers want to know that we are who we say we are. It can be as simple as sending in your pharmacy license, or if you have an immunization certificate or an MTM certificate. But think about how your organization credentials who you have. I think we've all done it. We've never written it down. But you don't just trust the person out of the box has graduated and they have the skills they need to be a pharmacist. And with fraud, waste, and abuse, HIPAA, there's a lot of different yearly requirements that can be built into your credentialing. And having that in advance when you ask for it makes a big difference. The future of the pharmacy HIT environment. Every year the meaningful use requirements go up. More has to be done in the interoperability between EHRs, EMRs. Health information exchanges have to be certified by the states. Most of the time, a health information exchange might be SureScripts, and they would be able to transfer information between a PBM or a doctor's office or a pharmacy, and you can ask for snippets of information. Or it can be full-blown where you actually go on the internet and have direct access to the EMR for any patient that you have a reason to look at. One of the things I've seen to avoid, especially going to the exhibit halls at many meetings, is most of our pharmacy software systems either don't have a clue or pretend to not have a clue about the necessity of us being able to communicate with other electronic documentation systems and to be interoperable. The standards are out there. There's a national group, again, of national associations called the HIT Collaborative. They have all agreed on a standard that's accredited by the accrediting agencies that accredit standards. So the methods are available, but we have to find ways to share and capture data through those systems. Also, that information will be about quality, safety, and best practices. So the more information they have coming from our systems, and we give a lot of information, as you well know, to a lot of other organizations, but we don't get to capture much on ourselves. So in order to be part of a primary care nursing home, in order to provide good care, you have to have all the tools. And part of that is going to have access to documentation. In their guidance letter for 2014, they're required to share 10%. Anybody who's got an electronic medical record system is required to share 10%. 10% of the information has to be shared with non-system entities. In other words, you have a big hospital system or a big clinic system, they're all constantly going to be talking among themselves. But in order to qualify for meaningful use, and meaningful use means more dollars for them, they have to be able to share their information with other entities like pharmacies. We're probably the biggest target for that if we can get them to do that in order to meet that 10% number. and requirements to earn Medicare or Medicaid incentives. Meaningful use is extremely important, and if they don't meet that, they lose big dollars. So if you know the language, you know what they have to do, that's an incentive to get what you need for get access to their records. And you need certified technology or health information exchange to use your pharmacy software. Every year new rules go up and there are more demanding requirements. And I would ask, are you ready? Who's talked to their pharmacy software vendor? Who's talked to their medical records custodians at their clinics or hospitals? And who has developed a patient medical record request form to satisfy HIPAA and list the information requested in electronic format. HIT needs, ACOs spell out what HIE and EHRs are necessary. You want to participate in an ACO, you're going to need to have access to personal health records, electronic health records, EMRs. And you're also going to have to be able to find data so they can measure your outcomes with patients. The nice thing about ACOs and pharmacies, there are 33 measures of the effectiveness of an ACO, and 26 of them involve medications to a different varying degree. So without a pharmacist who's evaluating those medication outcomes or contributing to more positive outcomes, it's really going to be hard for them to maximize their income. ACOs, I mentioned before, is a financial model. The top number is what payment will be. Anything under that, they'll get to save, and that curve is going to constantly decrease. So I'm not sure how long-term sustainable those savings are going to be. Pharmacy accreditation. I've heard more consternation and problems with pharmacy accreditation, community pharmacy accreditation, than anything that I've had in my travels around the U.S. this year. It came about, the boards at NEBP wanted to come up with a credentialing of pharmacists. I think, and I can't say this for a fact, it came about because they didn't have enough inspectors on a lot of states. They wanted to shift some of the state board inspection requirements to the state national accrediting agency. I got to go to a meeting of that, their framework and their development in June of 2011, along with Matt Osterhaus, a pharmacist from Iowa. There was NEBP folks, there was PBM folks, and there was a few chain folks, but there was absolutely no other practitioners. What scared me was that somebody else is developing the standards that we have to practice under, and we've done that way too often to let that happen. So out of that experience, we asked to get involved, we asked to get serious about it, work with NEBP, other national organizations saying, if we don't have some input on our standards, we're not going to support your project, which might not have been a make or break, but at least NEBP thought about it. So at the end of the day, APHA and several other national organizations came up with the standards that a pharmacy should be accredited. It has nothing to do with NEBP security, dispensing, licensing, but it sets a baseline for patient care and to advance patient care and medication safety. It harmonizes things with other accreditation programs like the DMEPOS or DME. After we got going and we're fairly far involved, the SHP came in. They're talking about using it to accredit hospital pharmacies, and now there's some talk about specialty pharmacies having this option. There's another accrediting agency called URAC that's dragging it into the process, but they also accredit PBMs and managed care, and personally I'd like to be at least an arm's length away from it. The domains, they have what they call standard domains, or practice management, which talks about policies and procedures, how you run your pharmacy. Patient care, to me, that's the big one. How do you develop patient care programs? How do you evaluate them? How do you document them? And then quality improvement. So do you recommend that your pharmacists have continuous professional development programs, etc.? The goal is to set a baseline and improve it every year until we get everybody in pharmacy, or anybody who wants to be accredited, improve their level of patient care in their pharmacies. It's already being talked about in PBMs and other pay-for-performance networks as potentially being a requirement to be in those networks. But at the same time, they've got to pay us or compensate us, cover us for that added level of cost. Almost other other healthcare has accredited accreditations and other types of quality control, continuous medical care, comprehensive, maximizing health outcomes. So you're going to see this roll out probably in the next year. It's optional, but you're also potentially could see being required for some networks, preferred networks, pay for performance. I think any way that we can get additional ways to get payment for when pharmacists provide care that remains to be seen if this is the answer. But for a not too complex, not too expensive accreditation, and it gets me paid for patient care, I'm all for it. Now, lastly, I'll talk about provider status. I think I've talked about, pharmacies talked about a long time, we should get paid for our services. We're not mentioned in the Social Security Act. There's lots of places we'd like to be listed, we'd like to get payment and bill services without connection to a drug product. There's the federal sector, which is the Social Security Act. There's the sustainable growth rate formula, which is a large body of legislation that pays doctors for their Medicare. And it sets a payment level for all the different services they provide. We could get mentioned in there and get included in that pocket of money. And there's all kinds of federal regulations. CMS could pay us tomorrow. AHRQ is a quality organization, and HRSA is the Pharmacy Services Administration part of CMS, the federal status. All of those could pay us. The thought process is we should get our mention as many places as we can that pharmacists are providers, and as many places as we can that says how to pay us. State provider status, some Medicaid departments pay for providers. Minnesota MTM, we're considered a provider, and they bill those services separately. Health insurance exchanges and state health plans, the state of Minnesota pays for patient care services for diabetes and smoking cessation. And then the private payer system. They can pay us tomorrow, but what has been seen in other healthcare providers, nurse practitioners, optometrists, physicians, it almost has to be led from the federal sector. So that's the way we want it to go. Why pharmacists? 50% of people are prescribed medications for chronic diseases. We all know that. 70% of Americans are on at least one prescription drug, and 50% are on two. Number of hospitalizations caused by medication misadventures is large and growing every year. And pharmacists are on the team, part of healthcare teams, patient-centered medical homes, PCOs, interprofessional, team-based care. Patients benefit because of enhanced satisfaction, care, and outcomes, and communities benefit with healthier populations. The healthcare system benefits because they have a quality product at an accessible location, and costs are improved. Provider status will enable other healthcare providers to have us on the team and reimburse us for our services. Why now? We waited a long time for this. It's something that's been in my sights for an extremely long time. There's growing evidence that pharmacists value every day in national media, in CMS, CDC, all the respectable healthcare publications, Journal of American Medical Association, American Academy of Family Practice. They're all seeing the light, and the ACO and ACA gives us more opportunities. There's immense pressure to come up with ways to take care of the acute goals of patients that qualify for more care through the ACA. Pharmacists are one of the most easily seen ways to increase the efficiency of existing providers and be care extenders or take care of patients in their own way. Congressional focus is difficult. It's not going to be an easy nut to crack. It's going to be a campaign. It's going to be a marathon, not a sprint. But we've made many contacts over the last year from Congress. We're considered that we are a saver, not a coster. We can save money and make the system more efficient. And the Hill equates provider status with fee-for-service. Fee-for-service will never go away probably, but it's going to be greatly reduced. We're going to have to share bundles of money with other healthcare providers. So now's the time to get in that new formulation and way we pay for care. They're not going to put up with an old system, but we can be part of and help shape a new system. So we decided we want to be providers. Well, that was easy. The next most difficult thing is, how do we limit the potential cost to the government for us being providers? What pharmacists, all or some? New pharmacists, young pharmacists, old pharmacists, just hospital pharmacists. Then the other way to control the cost is which patients. Do we offer it to all patients? And then we can say what services. Are we going to pay for diabetes management and not pay for smoking cessation? So there's all questions that have been addressed over the last year and a half by the national associations with help. We had a meeting with state executives, more than a couple of meetings with state executives, to see what they thought and what would work in their state. There's been a lot of recognition of the value. We need more publications. Harvard Business Review had a great article. There's been articles in all the national papers, multiple places, multiple times. Pharmacists are spoken very favorable. So it should be a good time to work on getting recognition for pharmacist value. Again, specific, predictable, measurable outcomes. And to this end, for the quality and predictability, potentially community pharmacy practice accreditation could be part of it. Outreach to medicine, make sure they understand what we're trying to do and not undercut it. And nursing the same way. And then develop a campaign that's going to be effective. CMS has been very supportive. In fact, that's been growing and very positive. The guidance letter that came out for 2015 came out this fall, and then the renewed letter, January 6th, talks about increasing Part D patients tenfold. Someone crunched the numbers and said 55% of Medicare Part D patients, depending on how you look at it, could qualify for MTM services. HHS, the National Action Plan for ADE Prevention, talked about every patient needing a medication review every year from a pharmacist and payment for that. ARC, the Research and Quality Organization, goes back to quality, said pharmacists were one of the few places that could make an impact if they started doing this immediately. Affordable Care Act, as the marketplaces roll out, all these new patients coming in. The White House petition, which students took a leading role to get the number of signatures to get a response from the President's office, came out. It's kind of a mixed message. The gentleman who wrote it obviously didn't understand the issue, which can happen. But that doesn't mean it didn't get a lot of advocacy and pharmacists involved. Harvard Business Review, the strategy that will fix healthcare, talked about having pharmacists playing a critical role. Redefining the patient experience. One thing about provider status is that we must earn it. It's not going to happen without pharmacists going out and trying to get it. And then we must own it. It can't be somebody else doing it for us. And that means a unified number of pharmacists. A little bit of history on the campaign. It started in 2011. APHA committed $1.5 million in the hopes that other organizations would commit, national organizations would commit time and resources, and they have stepped up. There's a broad stakeholder group that continues and evolves. It's had several permutations, but major players in pharmacy are involved and being very conciliatory in trying to have a unified ask and not have different messages going to all the key players. I think that's important. Some of those researches have been spent on Leavitt Partners. Many of you remember he's been active in several presidential secretary jobs. And SNR Denton is a premier lobbying agency, and they've gotten us great responses, great information, and a lot of it we didn't want to hear, but we needed to hear so we didn't go down the wrong road, because this is going to be expensive when we can't afford to make mistakes. The things that I've been involved in discussions with AMA and the American Academy of Family Practice, the American Academy of Pediatrics, American College of Physicians. And when you sit down with their leaders and their management in the same room, they're not bad people. And they understand what we're going through and trust us to educate them on what we're trying to attain. And they always have suggestions, but it isn't close the door to bother us. It's how can we make this better as long as we include them in the conversation, because obviously they'll be very critical. We started with medicine. We know nursing is going to be a problem. We do a lot of things that they would like us not to do because they do them well. But as far as medications, we need to do that. There's continued collaboration between organizations that haven't been able to collaborate on many things. are collaborating in a very positive way on this. First thing was to develop principles that guide consistent messaging around advocacy. Access to care. Pharmacists are everywhere around the country. They're more accessible than any other provider. The quality of our care. We're the second highest college-educated profession behind physicians. We're underutilized. Some would say overeducated, but I would say we can use that education to provide the best possible care. We're good at controlling costs, like I said earlier. We both know the economics and the therapeutics of medication. Nobody else knows it as well. Pharmacology, physicians have 3 or 4 lectures where we have semesters of pharmacology in our education. Team-based care, we can be what's missing in most teams are pharmacists. They're in hospitals, they're in certain situations, VA hospitals, but in the average community clinic, there are pharmacists involved. So that's an area for us to improve and improve the care that those patients are getting. Patient-centric, we deal with patients one at a time in our pharmacies, our pharmacy practices, wherever we are. And the big high intensity of care transitions and readmissions, they know their savings on a hospital level. Hospital pharmacists are doing an ever-increasing quality job of making sure those readmissions don't happen from a medication event. And the next step is to hand those off to community pharmacists or the pharmacists who are going to follow them once they're out of that window that the hospital folks will take care of. The Pharmacy Coalition activities, we meet at JCPP, which are quarterly meetings, with the presidents and the CEOs of the organizations. The CEOs and I meet with other CEOs very regularly. And then probably most importantly, and an MPA is no different, the staff meets with the other staff, and then they really get things done and bring it back to the boards of those respective organizations. You can see the folks that are actively working in the coalition. It's a lot of alphabet soup. And 2 major chains are very positive and will be carrying the water on the Hill with the dollars that they can invest. And they've been very accommodating to the wishes of other people and other coalition members. Beginning in July, we hired a high-test lobbying legal firm to start working out the legislation. Should it be regulatory or legislative? Should it be in Part B or Part D? Medicare ACOs or the Patient-centered medical home? That language is distributed all throughout the Medicare, Social Security Act, and other bills. The thought process is we're going to concentrate on Part B. We have a very good Medicare Part D bill. We're just going to keep that simmering. Hopefully that passes. And then, like a bill like with Senator Harkin recommending that pharmacists be part of ACOs, we're going to take every little piece of legislation or every little piece that pharmacists will be mentioned in any federal legislation in a positive way for patient care. And then the real prize will be pinning on Medicare Part B. And that has been agreed upon by all those educations, all those organizations. I mentioned Avalier is a huge research company. They're out there looking at all the literature that says anything about a pharmacist helping anybody anywhere. They're trying to build an independent database of support for pharmacists being providers. We've got lots of our own information, lots of our own data, but that's considered self-serving and does not carry the weight of a company like Avalier. Even though they're not independent, they're taking our money, but it's much better than our information. And they're doing systemic literature evaluations, gap analysis, related recommendations, and they'll be releasing a white paper hopefully in the next month, talking about the good thing pharmacists do that we can use on the Hill. Doing a communication strategy with members, pharmacists, and key stakeholders, including patients. It's going to be expensive. We need every pharmacist, young and old, in every practice setting to have a unified message when we go to the Hill to get provider status. There's on our website at ADHA, there's a special section devoted to current information when you're going to talk to somebody. Collecting stories and evidence on the return on investment, which has been large in any place that's been measured in the past, mostly by pharmacy. Advocacy with key education committees, lobbying members, congressional committees, national organizations are on the Hill all the time, and this is part of their repertoire when they're talking about bills, and so will be high priority, if not at the top of the list for most national organizations. Had health fair where they had more than half of congressional staff and congressmen, women came through, and pharmacists from St. John's, from Howard, and one other college in the area, showed them how well we train our student pharmacists, and was very well received. They're going to continue to do that. Activities around the SGR, that is going forward. That's changing fee for service to other payment models for primarily physicians, but once they set the physicians' rate and how they're paid, everybody else trickles down from that. We want to make sure pharmacists are part of that. And we're conducting research with the Public Relations Forum with policymakers and voters. And it's been very interesting what has come from those public relation folks about pharmacists, what they think about what we do, and what most of them think we should be providers, but most of them think we're somewhat self-serving in how we carry the message. Policymakers, in most cases, are neutral to the idea, and as long as our ask, our valuation doesn't cost too much, and we're saving money, costers, not savers. Savers, not costers. Very important. Some of the things you can say, we need elevator speeches. People on complex medications benefit from pharmacist services. When pharmacists are involved, costs go down and quality improves almost every time. If healthcare spending and outcomes are to be optimized, benefits in healthcare systems must include pharmacists. That's where the gaps in care are. And patients should have access to pharmacist service in federal programs, state programs, and private insurance programs. I think that would happen once we're mentioned as providers. Some very cool things are going to be happening in the next couple of weeks, if not by the next 30 days. The federal ask, the language has pretty much been decided on. We've got about 3/4 of the sponsors we need in the House and Senate. We're going to get all those national organizations and coalition members who have a single communication strategy and talk the talk. Accelerate ongoing advocacy. You haven't seen that as much as you're going to see because we fired experts on how to get the message out and have a crescendo, a growing momentum on provider status. But it's got to happen from everybody, every pharmacist in every corner of the country. And there'll be a lot of involvement in national and state associations. Probably be kicked off in mid-March. There's a huge fly-in for any CDS, NCPA sends folks to that. ABHA folks will be there. Students from local colleges. At the ABHA annual meeting at the end of March. At NCPA's legislative day at the beginning of May, usually when it's held. But provider status will be on everybody's lips, and we'll hopefully have the same message. This is mostly the draft bill language. It could change, and as everybody who's lobbying on the Hill and who's contributed to a PAC knows that what you submit isn't always what comes out. But the intent is to say every service furnished by a pharmacist, and what I talked about earlier, that's legally authorized to perform in the state in which the individual performs such services. In other words, your scope of practice has to let you do what you could get paid for. And so we're not going to limit who can do it. The government, someone else might decide to put extra credentialing or privileging on it, but the ask we're making is any pharmacist who's licensed in a state and their state scope of practice allows them to do could get paid for these services. Starting out like nurse practitioners do, especially appealing to where the primary care shortage is, health professional shortage areas, and medically underserved areas and medically underserved populations. Those are areas that are defined in the Public Health Services Act and can be specifically, usually by county. It's not going to be across the country. I'm not sure the affluent areas in Michigan, there probably won't be one of those. But there will be well-defined areas. Once success has been attained by other professions by doing that, it's usually rolled out to everywhere a patient needs services. And the other thing we put in the bill that amounts shall be paid be equal to 80% of the lesser of the actual charge or 80% of the usual fee, which is what nurse practitioners, advanced nurse practitioners are able to do. So it certainly is economically viable if they would accept that language. They'd have to implement and develop new billing codes specific for pharmacists, because again, part of everything that's going on with healthcare is gathering data, so they're going to want to know we're providing the services that we're billing for. The good part of that is as we provide better outcomes and better patient outcomes, better service levels, practice at the top of our education, it'll show that pharmacists are doing it, not nurse practitioners, not physicians. And it should show that pharmacists who are on healthcare teams are essential in attaining those quality outcomes. We're changing, we have a Pharmacy Practice Act committee in Minnesota right now, and we're going to introduce some language to change our scope of practice. We have quite a few things that we can do, but it's nowhere near where we'd like it to be. So we involve students we only have one college which has an extended campus up in Duluth. The main campus is in Minneapolis, but the student pharmacists have been very active in changing the scope of practice, which was changed in 1937, which is time to change it. But they said we're clinicians, not like drug librarians. Back in the day, pharmacists were depended on for their knowledge, but not necessarily depended on for the quality of their care, or were not considered clinicians. And their reasoning was consciously define and refute a perception of pharmacists while emphasizing the clinical decisions pharmacists can and do make every day. Support can include the last major overhaul of the Pharmacy Practice Act was in 1937, prior to the explosion of drug options and information. They also want the opportunity to practice at the top of their education. Our pharmacists, and I'm sure Michigan as well, are extremely intelligent, good practitioners, but there are very few places they can practice their profession. Their rationale is that they're the second highest educated health professional next to physicians. In Minnesota, there are 3 lectures on the topic of specifically and only pharmacology, where in Minnesota they get 3 semesters. And pharmacists provide a needed and useful role in the healthcare team in areas of therapeutic and generic equivalents for all pharmacists, regardless of particular setting. They're professionals, not licensed. I think we're seeing a growing rationale of dividing pharmacists as providing care. Pharmacies don't. Pharmacies provide a place to practice, and a part of being accredited means your pharmacy provides a high-level place to practice pharmacy. It doesn't need to be anchored to a location as long as you have good electronic medical record access anywhere. And renovating, we have to renovate the legislation in order to innovate. There's so many new entities, ACOs, healthcare homes, and other future healthcare delivery models that pharmacists need to be a part of and can't do in our Practice Act, as we see now. Pharmacists will be recognized when pharmacists practice at the top of our abilities. Pharmacists are valued members of the healthcare team. Every patient has a medication checkup performed by a pharmacist. The healthcare team has access to pharmacists. Pharmacists are embedded in most large medical practices. Standards are met and ever rising to improve quality in healthcare, and pharmacists contribute in a major way. Pharmacists have read-write access to electronic health records. Interprofessional education results in interprofessional practice. Pharmacist patient care process is taught uniformly in every school of pharmacy, and pharmacists understand their roles on the healthcare team. All those, we need to have a majority of those happening, and we know we've been successful in getting our message across about the value and quality of what we do. I think it boils down to all of us and how we want to practice, how you want to practice. We do have a choice. I think you made a good decision being a member and coming to the MPA meeting. Use your association's muscle to improve and raise the water for all the votes in pharmacy. Get involved, make a difference in your career, in your community, in your profession. I like to show this slide because half the time we would get what we asked for if we just tried. So I don't think it's any different for the patient care process. So I encourage you to get the reward of high job satisfaction by improving your patient care success and the opportunities. Again, we're very capable providers, but we have to shape and change an incapable system. Thank you very much.